Hi, I'm Dr. Gil Welch. In this Less Medicine, More Health short take, we'll consider observational studies and confounding. And if that word confounding feels a little confusing to you, you're half the way there, because in fact confounding refers to confusing the source of the effect. This issue comes up in Assumption 1. All risks can be lowered. And let me give you just a little background. Risks to human health are almost always identified from observational studies. Intervention to lower these risks are often supported only by observational studies. And finally, observational studies are subject to confounding. Let's go over the two basic study types. There are experiments and there are observations. When you think about experiments, I want you to think about patients being allocated to one intervention or another on the basis of chance, the flip of a coin. And of course here you'll be thinking about randomized trials, even though we don't flip coins anymore. Observations, no one's saying what the patient will or won't do. The investigator's simply looking at patients based on what they do. And there are lots of observational study designs, things like case control studies, cohort studies, cross-sectional studies, ecologic studies. Now you might be tempted to think, why don't we always do experiments? And the reason is because we cannot randomize if the exposure is believed to be harmful. Can you imagine a randomized trial of smoking cigarettes versus not smoking them? No, that's not going to happen. But the problem with observational studies that I want you to consider here is the problem of confounding. Now, to understand confounding, it helps to understand the relationship between exposures and outcome. It's the generic study design of all medical studies. We're always trying to relate exposures to outcome. And most people think of exposures as a bad thing, something like cigarette smoking. And the question is, does it cause the outcome of lung cancer? But in medical care research, the exposure might be something good, like the treatment of really high blood pressure. And there the question is, does that cause some change in the outcome of cardiovascular events, hopefully lowering them, which it does. So medical research is about relating exposures to outcome. Now, as I said, observational studies are subject to confounding. They're trying to relate exposures to outcome, but there's a third variable out there. It's called the confounder. Sometimes it's called the admitted variable. And if it's really a confounder, it is something that is associated with the exposure that in fact is what's driving the outcome. So the apparent relationship between exposure and outcome is confounded by that third variable. I know that's pretty abstract, so let's think of a real example. Consider the exposure of watching TV. And the question is, it appears to be related to weight gain. But wait a minute. Is there some variable out there that's associated with watching TV that in fact leads to weight gain? While you're thinking about it, pass me the Cheetos. Oh, that's a hint. What do people do when they watch TV? Well, they might snack a little bit. Or what don't they do? They don't move much. They're inactive. That's what leads to the weight gain. The apparent relationship between watching TV and weight gain is confounded by snacking and inactivity. Here's another one. Imagine the exposure of eating chips, or Cheetos if you want. It appears to be related to the need to urinate. Is it really eating the chips, or is there something associated with eating chips that in fact drives the need to urinate? What do you think? If you chose drinking beer, you and I are on the same wavelength. But of course it could be drinking water, soda, iced tea, whatever. Oh, here's one I like. Volvo for life. This was an advertising campaign for Volvo cars. It suggested that if you really cared about your life, you'd want to drive a Volvo because it's a safe car. Now is the time to get your cultural biases about Volvo owners out on the table. Imagine who they are. They're older folks. They're more affluent. They might even live in Vermont, be liberal or something. Oh, that's me. Anyway, back to Volvo for life. Observational studies are subject to confounding. Let's say Volvo is associated with fewer accidents. Is it really because of the car? Or is there some other variable out there associated with who owns a Volvo, who drives a Volvo, that in fact leads to fewer accidents? Well, you get the idea. It's the type of driver. Someone who's older, someone who's more affluent, someone who's more likely to have children in the car, someone who cares more about safety. That's why they bought the Volvo. You want a medical example? Think about Premarin. It's a form of estrogen. Here's their website in 2001. You could roll the mouse over each one of those women. They tell you about the virtues of Premarin. They were all taking it as a preventive intervention. And in fact, there were hundreds of observational studies showing that hormone replacement cut the risk of cardiovascular disease in half. That's a lot. But observational studies are subject to confounding. So, women who used hormone replacement, that's the exposure, were observed to have a lower risk of heart disease. But was that really the cause? Or was there something associated with hormone replacement that in fact lowered the risk of heart disease? Well, actually, there were a lot of things. Higher income, more educated, less smoking, more exercise, better diet. The women were healthier overall. And this is a generic problem for preventive interventions. Observational studies of preventive interventions are particularly likely to be confounded. It's called prevention bias. Any preventive intervention will often appear to be associated with a lower risk of death. But the question is, what is associated with people who take preventive interventions that may in fact lead to lower risk of death? Well, it's their higher health status overall. People who are drawn to preventive interventions tend to have fewer other health problems. They already have health-conscious behaviors. They're the people who already are less likely to smoke, more likely to exercise. While people who are sick, they're less interested in preventive interventions. They're much more likely to be interested in reducing their symptoms they're currently having. So there are experiments and there are observations. And it's tempting to think that there's no role for observational studies. But that's not true. Observational studies are important for generating hypotheses. They're important for learning about harmful exposures like cigarette smoking. They're important for testing exposures not easily controlled in an experiment. Questions like how frequently patients are seen by their doctors, how frequently they're tested, or how frequently they're referred to specialists. And it turns out observational studies are important in investigating the extent of overdiagnosis. A story for another day. Here's my general rule. If we are contemplating an intervention in healthy people, such as a drug, we ought to test it in a randomized trial. The assumption is that all risks can be lowered. But that assumption is often based on observational data that are confounded. And all of our interventions pose some harm. That's why the disturbing truth is risks can't always be lowered, and trying creates risk of its own. I hope this helps. Thanks.